Oops. Oh, there were panel or attendees and now they're gone. That was weird.
Yeah.
Well, that's really weird. There was 3 pending attendees and now they're gone. Oh, there's one. Okay.
Kristen, one
Hi,
thing I didn't.
welcome.
That on the timeline,
Yeah.
it
Hi,
threw
Lisa.
Kristen off. There are
Yeah.
3 people and then they ghosted her.
I know they're here. Hi, Lisa. Hi, Elizabeth. Hi, Wynn. We're going to get started here in just a moment. Thank you for joining us. Good to see some of the familiar faces from last week's session. I am going to put in the chat box. Hi, Sheila. Put in the chat box a link to our pre-session questionnaire. If you guys could take a few minutes, and not even a minute, won't take very long, but go ahead and complete that for me really quickly. And in about a minute, we'll go ahead and get started. And I'll start by going over some logistics, and then Dr. Celeste Harvey will dive right in today. And Celeste, you could just show the landing page for slide 1. That'd be great.
Yeah, I was working on that right now.
Thank you.
Trying to make sure my boxes with faces were at the top. But I think the chat box is going to be on the right.
I've got on the right. I got you.
Woohoo!
Okay, so we're going to go ahead and get started here because we have a lot of content to cover. So welcome and thank you. Hello again. I see in the attendees list right now, we've got Elisa, Elizabeth, and I'm sorry if it's Alyssa. I'm butchering your name. I apologize. Sheila and Wen. Again, I put a link to the pre-questionnaire, pre-session questionnaire in the chat box. I just need you guys to take about 30 seconds to complete those 5 questions. Similar to last session, and then at the end of today's training, we'll do the post-test. So I'm going to turn it over to our trainers. Dr. Mark Harvey is going to introduce himself, and then Dr. Celeste Harvey, and then we'll get started.
So I'm Mark Harvey. I have been working with NADD for about 4 years now. My background is in special education and working with individuals who have intellectual and developmental disabilities. Been doing that for, I'm going to go with 35 years, even though some people may say, well, it's more than 25 because they don't want you to know how old you are. But, you know, that's how it is. So, yes, I'm old. I've been working in the field for a long time. I'm going to be the web chat monitor for this. If you have any questions, please put them up there. Let me know how that's working, and I will monitor that. And with that, I'm going to turn it over to Dr. Celeste Harvey.
Thank you. Thank you. Hi, I'm Celeste Harvey. I am an associate professor at the Chicago School in Dallas, and I've been working with the National Association for the Dually Diagnosed now for about 5 years on different projects. I'm so happy to be a part of this project. I'm one of those people who will say more than 30 years or more than 25 years because I'm trying to hide how long I've been doing this. I started really young. I was a teen. Actually was. That's a true story. But I've worked with people from very young, age 2 to actually 100 years old, because I work in behavioral gerontology as well as in early intervention. And I've worked a lot with deinstitutionalization of people with different diagnoses, intellectual and developmental disabilities, secondary mental health disorders, even some who struggle with addiction as well. So over the years, working in community settings, primarily, institutions, community settings, schools, even a jail system in another state where I worked. And we had a lot of these kinds of concerns that we're going to talk to you about today. And I learned a lot from others, from the people I served, but also the people around me, about how to be very mindful about planning, being as conscious as we can of what a person is doing and how that reflects what they're perceiving, how they're feeling. So as Dr. McGill pointed out, there is a pre-session survey here that I would like to have all of you take. If you are just joining us, I see a few chats popping up. So please take that little pre-survey. Well, the purpose of it is to test you a little bit at baseline to see your responses to some of the questions that we're going to be asking. And then there'll be a little quiz again at the end. You'll see this survey again if you loved it. And even if you didn't, it'll come back for you to have a chance to show your responses so we can see that we've done something today to be able to prepare you. Anything exciting in the chat right now, Mark? Okay. With that, I will tell you this fine print is, you can certainly read it, written to thank the Florida Developmental Disabilities Council and the National Association for the Dually Diagnosed, where we work, for providing funding to sponsor the development of this training and implementation. That it's important for you to know that the words that I say today, the content that I present, comes from my research, my background, as well as the other team members who helped develop this. So it does not reflect FDDC or NADD's perspectives directly. And so if you have any questions, please pop them in the chat for clarification, or if there's anything that you just want to share. We'd love to hear from you, because that's how we make things more interactive when we're doing a virtual training this way. So we're so glad you're here. All right. So you should note that the definitions and eligibility requirements vary across age ranges, states, and service systems. What I mean by that is that you may find that if you're coming from outside the state of Florida, eligibility for services changes, access to certain supports may be different. And then we have a resource list available for you to contact for more information, and we'll share all of these slides with you. Everyone will get access for some of them that are clickable. You can go in and look later. So some of our plans for today, we're going to talk about strategies to prevent crises and the importance of early detection. We're going to identify pre-crisis behaviors, work on determining signs of an impending crisis, and we're going to describe the importance of early detection and early steps to take. We're going to teach you a little bit about how to work with an individual to complete 2 worksheets that incorporate their input. One is on tips to manage triggers, and another is called What to Do When I Don't Feel Okay. You'll learn to use the red panic button phone app for folks who may be out in the community and need a way to reach people urgently and quickly. And we'll talk to you about developing an individualized crisis plan. So this training is going to cover, first of all, some identification of pre-crisis behaviors. We will talk about why detecting early signs is so important. We'll talk about planning proactive trauma-informed care, some pre-crisis prevention strategies, how to involve individuals in their own crisis prevention and crisis response planning, how to use an app for help in a crisis, and how to utilize a crisis plan. It's important to tell you, first of all, that some of this content may be sensitive. It's important that you practice self-care. If you are feeling stressed, it's important to monitor those stress levels, step away if you need to. You can text a peer, a friend, a mentor, or a relative. Maybe you want to curl up with your cat or your dog. Let's listen to some nice music, aromatherapy. Breathe, lots of great things you can do to help calm yourself if anything is stressful for you. So for starters, let's talk about how to identify pre-crisis and precursor behaviors. So one of the questions that we often talk about when we're working with a team dedicated to supporting individuals with intellectual or developmental disabilities who also may have co-occurring mental health disorders, they'll say the person had a behavioral or mental health crisis, and we go, what does that look like? And if you notice, the word look is in quotes. What does it look like? And the reason is because a lot of people will use terms for what a developing crisis feels like or what we perceive, like what we think. But what we need to do is focus on as much as we can about the observable, identifiable behaviors or changes that we note are existing in a developing crisis. So, what it looks like is going to tell you more about how to act and when to act, right? So if we're looking at what it looks like, what we want to do is develop a description based on past events such that other people will also know, oh, I need to look for someone who starts wringing their hands vigorously, or maybe they make a certain groaning sound that's indicating a possible developing crisis. It's because what we want to do is be able to respond at the appropriate level of pre-crisis if we can. If we see some precursor behaviors, we want to be sure that we're able to interact with a person, maybe touch base. How's it going? What to do during a crisis to try to de-escalate, and also what to do post-crisis after the event has occurred to reestablish that steady sort of homeostasis, returning to stability. All of those things are so important. So it's important for us to think about what things look like as they're developing, write them down, talk about them with a person's team so we can better intervene at the right levels to always work on de-escalating. So when we talk about identifying pre-crisis or precursor behaviors, it's important that we identify what it looks like, what you can observe, so that others can also be able to agree on the occurrence or non-occurrence of the concerning behavior. So in other words, I mentioned earlier, the like if you're seeing someone wringing their hands kind of hard, or maybe even a loud hand clapping. I once worked with a man who would clap his hands really loudly and hard together until they were quite red. Body rocking, right? So we can agree, if we describe this, that another person could look and see what we're describing and say, that's an instance. That's the same behavior that Celeste described, where he's wringing his hands or he's clapping hard or maybe body rocking, making certain sounds. Those are the kinds of things that we want to write about and discuss with the team so we can note them and be ready to identify and operationally define like what it looks like, right? It involves describing something you see as accurately and concisely as possible. So, exactly what it looked like, what it sounded like. Sometimes I see really unclear descriptions of things, or I have to ask for clarification, or even ask someone to model it for me. Can you tell me like what you saw, what it looked like? I once had a man that I worked with write a behavior intervention program, and it included that the client would get a blip on her forehead, a red blip. And I had to ask him, like, what does that mean? He said, oh, she'd get like this little red spot right in the middle of her forehead. I was like, that might be a little hard to see, but can we talk about some other things that are really apparent that we would look for? So if you imagine you're responsible for writing a description, so anyone reading it would be able to say, yep, that's an instance, or no, I think that's probably not an instance. That's what we're looking for, right? It could be countable things, right? That we can look at, like the numbers of calls or texts increasing, or increased complaints, verbal threats, people who are making remarks about themselves that maybe they're not happy with something about their lives, those kinds of comments. These are the kinds of things that we're looking for to be able to identify a developing crisis. And sometimes these things are really observable. They're obvious when they occur. So if someone is making a verbal threat or saying they're going to harm you, that's something you notice. You hear it, you see it, and it might give you that sense you need to back off a little bit, give a person a little more breathing room, or maybe you do need to get a little closer to check on them and see if they're okay. Knowing the person is so critical. Everybody does this a little bit differently. Damaging or destroying property, those are other examples of things that are really generally apparent. We can see them really clearly. Injuring themselves or injuring others, those are examples of things that are really obvious, usually overt, observable signs of an impending crisis. Normally, if someone's making threats to me, I know it's time for me to increase my proximity, be ready to listen and be supportive, and be prepared for possible escalation and work to reduce. I usually talk about when people get louder, I get quieter, right? They go high, I try to go lower, listen, and try to be supportive. Then there are also some hidden signs, and these can be less obvious, a little harder to see. Things like withdrawing from highly preferred activities. Someone is just less engaged in their daily routines. Maybe they're withdrawing to their rooms. They're eating less or eating more in some cases. There may be changes in sleep. That's a big one that you frequently see, that we frequently see. It could be sleeping excessively, like throughout an entire day, or it could even be very little sleep for multiple days in a row. Worsening hygiene is another example where someone is not doing good self-care, maybe not brushing their hair or teeth, or not showering. So these are the signs that generally are not as overt as the previous ones, but we may start to notice that, Jimmy has been in his room, sitting in his bed with his covers pulled over his head all day. Check. You're like, is he feeling unwell? Does he need to talk to someone? Is it time to call his team? So these are the kinds of things that may not jump right out at you. In another discipline of psychology, a lot of my therapist friends will talk about internalizing, externalizing behavior, right? And I think that it's similar to how we talk about these things that may be overt and observable, and those that may be more discreet or difficult to detect. The internalizing behavior may be things like this: the withdrawal, the changes in eating and sleeping, that are a little harder to notice, but still really important. So it's time for our first quick little quiz, and I'm going to ask you to enter an answer into the chat box, if you please. So often the signs of a developing crisis are apparent or obvious, but they may also be, what do you think? Is it A, attention seeking, B, nuisance behaviors, C, ignored, or is it D, covert or hidden? What do you say? We getting some answers over there, Mark?
You are. You're getting, I think they're doing this in code. DADD?
Mm-hmm.
Yeah.
If people are answering A, certainly there are people who will say maybe this is attention seeking, that someone is seeking your attention with these behaviors, and I do understand that response. But the correct answer, oh, should I move on?
No, you go for it. I would say too. Yeah, I think the best answer would be D. Is that correct?
It is.
Covert or hidden?
Yes. And so I understand attention seeking, and that can be an appropriate thing in some cases. We want people to seek our attention when they need help. But understanding that these things may be covert or hidden is like at the core of what we're trying to talk about today, right? Nuisance behaviors, I sometimes hear people call these kinds of behaviors nuisance or even junk behavior. I don't know if you've heard that term. And I think, well, let's pay attention, right? Let's take a note of some of these signs that may be harder to detect, just observing. Okay, very nice. Thank you. So now is another little chance for y'all to enter some information in the chat. So let's look at these examples of observable behavior. And if you remember, I talked about things you could actually see, hear, someone that you observe that you might be able to tell this is an observable precursor. All right. So not talking about a state of being or thinking or feeling that someone else is doing, because we don't always know like what they're thinking or feeling, but what are they doing? Okay. So the first one, would you say this is an observable behavior? Harry is agitated. What do you think? Give me a yes or no in the chat. Give us a yes or no. Harry's agitated.
Another mix, no, yes, S.
Okay.
Yes, so, well, very nice.
It's mixed, right? Okay.
Yeah.
Is it the trick one? It could be. Agitated. Okay. Who could tell me what it looks like put it in the chat when you're how you would describe agitated? What do you do when you're agitated? What are some things if you want to admit? Or you could say someone else. My friend paces the room or whatever. What are some things you do that indicate you're agitated? Anybody?
Get it started. Pacing was
Oh,
mine.
pacing.
Tapping,
Yes. Pacing, tapping. Right. Can you
flicking the
see it?
nails,
What?
crying, walking
Yes.
around the room, flicking the nails, a
Right.
frown or fidget.
Those are observable, right? Those are behavior. Agitated, what you just pointed out right there in the chat is exactly the point of this. When we think about precursors that are observable behavior, we want to be able to note those individual changes in a person. So if you're a person who taps your fingernails, I think it was, or cries, etc., those are the things that make sense in terms of observable behavior. Agitated can look very different for different people, right? Different people do different things. If I need to know that Harry is pacing the room and that's what has happened in the past before he throws something and destroys it, then I want to know pacing might be a precursor. Cool. Okay. Frederick says he hears voices that tell him to hurt people. Observable? Yes or no? Pop it in the chat, please. Frederick says he hears voices that tell him to hurt people.
Yes, we got a no, and a yes. If he tells you he hears them.
Yes. Okay, so this is another one that's interesting to think about because we may think about Frederick hearing voices that we can't hear, right? They're within Frederick's brain, right? But if he says that he hears the voices, then that becomes an observable behavior. We can hear him telling us that he's hearing the voices. We can't always tell if it's true, but I'm going to take it on faith. We know that in the past, Frederick has said he hears voices that tell him to hurt people, and then maybe he makes attempts to hurt people. Then that's observable now. He's taken something that's like an internal or private event and turned it into something that we can then listen, interpret, and understand. Okay. Very good. Thank you for your participation. It helps. Shaniqua is throwing things in her room. Observable? Yes or no? Throwing things in her room.
Yes, 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 yes.
Yes. Very good. Yes, 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 yes. So throwing things in the room, something we hope we never see, but if we see it, it's observable, right? Okay. Trick one. River is sad. Observable or not? Sad. And when I ask it, I'm going to try to prompt you to think about agitated, the earlier example, agitated, sad. What do you do when you're sad? What does it look like? If you just say you're sad, it could look different to different people, right? Anybody pop anything in the chat there? River is sad. Is that observable? Yes or no?
We got a yes, we got a no, that it's manifested differently in different people, but also a maybe. It depends on body language.
Mhm.
Exciting.
Okay. Got it. So River is sad. We're taking an interpretation of his state, and I'm trying to like work us toward what is it that he's doing that we interpret as sad. I know, right? Because we think we know what sad looks like, but and we can, right? We can look at whether someone's frowning or whether they're smiling. We can look at someone crying. Maybe when someone's sad, someone is experiencing sadness, they withdraw to their room. I once worked with a young woman who would say, I hate you, you hate me. I wish I wasn't here. those kinds of like depressed statements. And I could say she was sad, but I could say, when Elizabeth is making comments about not loving other people, that people don't love her, she hates herself, she doesn't want to live, those are examples of observable behavior that indicate sadness, right? Okay. Cersei says nobody loves her and she hates herself. Observable? Yes or no? She says nobody loves her. She hates herself.
Yes,
Observable
yes,
behavior.
yes, yes.
That's correct. Right. Something she says. So look for those active verbs. I know that I'm a behavior analyst and I tend to think in terms of behavior, but the reason this fits for these examples, I believe, is we're trying to get closer to being able to describe what we see or perceive so that we know when to act. Okay. Okay. Bob cried in his room for 3 hours last night. Observable, yes or no? Pop it in the chat. See what we think.
Yes, 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 yes.
Yes. Okay. So crying, active verb, right? He cried for 3 hours. That tells us we may need to check in on Bob, make sure we're aware of his behavior, but also like if there's any potential risk of this carrying over into a worsening crisis. Bernice made threats to hurt herself. Is that an example of observable behavior? Yes or no?
We got all affirmatives and
Okay.
one note for Cheryl to say it needs to be more specific. Verbal threats, written threat, etc.
Okay. Um, the point, I guess, stands. Like we could look at it as at whether it's spoken or written. Uh, I could add the word written in there or spoken. Sure, we would want to know that, right? We want to know, like, what does that sound like? When I write plans like this, I often give an example. Like I'll write out, for example, if Bernice says, I'm going to cut myself with a knife verbally, right? Then that's what we want to know. So, right. Victor stripped off his clothes at the mall. Observable, yes or no?
Yes, 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 yes.
Okay, right. Very, very observable. Unfortunate when it happens. Teresa has a period of anxiety that lasts 3 days. What do you think? Observable? And like, let's think about it like carefully in terms of like how observable it is. Like, is this what does anxiety look like for one person versus another? How do we know Teresa is anxious? What does she do? Yes or no?
Got some mixed responses, but several of them are noting. In fact, anxiety looks different for different people. We need a description of anxiety.
Yes, that's the goal, right? So all of these that we're like, oh, we need more information. You're right. We need to get closer to that information about what it looks like, identify it for an individual so that we can then figure out when we need to intervene, when we need to make contact, check in on a person, start looking into whether there are any medical changes or biological changes that may have contributed to behavior. Like when you see that there's a period of anxiety that lasts 3 days, it's like, what does that look like for Teresa? Is she calling all of her friends on the phone and yelling? Is she starting to make threats to harm other people or herself, etc.? So thanks for all your contributions. It's great to see that you're locked in. All right, we're going to move into why detecting early signs is so important. The best predictor of future behavior is past behavior. If we see from a current event we could argue that there's always a first, right? There's a first time for everything is a phrase that we use. So we look at something that's occurring. Maybe someone ends up having a call to 911 because they've damaged their home. They've thrown some furniture around, and we think, uh-oh, this is new. But maybe we need to look in a person's record or talk to people that know the person well to figure out, has this occurred in the past? Right? And so if we see that certain types of events have occurred in the past, then we can start looking for more precursors from prior incidents to figure out what happened in the days, hours, or weeks before a call was made to 911 or a person was maybe taken to the emergency room or maybe a hospitalization. So we can start to look for a pattern before event occurred. We want to know when the last serious incident occurred. So again, looking at records, talking to people that know the person well, who was involved in that episode or that serious concerning event. What did it look like? Okay, exactly what did the person do? Where did it occur? Was it at school, at home, the grocery store? Were there observable signs or precursors to a building crisis beforehand? So things that we could pinpoint or target that are really potentially early signs. The first thing I start to think about is ruling out medical issues. Were there medication changes or errors? Dental problems that are a big problem. I worked with a 16-year-old woman who suddenly started punching her jaws with both fists. And when the team discussed this seemingly out of nowhere behavior, it became apparent that we needed to get her fully checked out, take her to the physician. And then she went to the dentist and they found that she had severe decay in several of the back teeth. So she had basically rotten teeth in her mouth that must have been extremely painful. So the teeth had to be removed. She had to be on some antibiotics for a while to heal the infection, and she improved. But this is one of those things that we needed to look for and immediately get in and get her seen to be able to get her the treatment she needed. We would also ask if there have been recent changes at home, in the community, with friendships, or with family, because as we all know, when things change in our home lives, they're going to have effects on us, on all of us. And certainly for people with communication impairments, certain types of disabilities, it may be harder for them to communicate those things, those events. So identifying the early signs gives teams an important opportunity to intervene and hopefully avoid an escalation, risk of harm to the individual or others in their environment, to avoid interactions with first responders who may not understand the person's needs, to avoid a psychiatric hospitalization, and certainly to avoid risk of trauma to the individual and the support team. In some cases, the individuals that we support who have a dual diagnosis, so intellectual or developmental disability and or a mental health diagnosis, there may be impaired communication. Many years ago, when I worked in a different state, there was a young man who was wandering around the parking lot. He was banging on some car windows and screaming. And when the police came, they just saw a man who they thought was potentially dangerous. They didn't know that he had a diagnosis of autism spectrum disorder and was nonverbal. They just saw a man who was yelling and threatening. So they approached and used some pretty abrupt procedures to take him down to the asphalt in the parking lot before someone showed up to explain that this man had gotten out of a van. He should never have been left there sitting alone in the first place. And once that was explained, they were able to provide better treatment. But you can see that sometimes people who don't understand the purpose, who are probably well intended, they're hoping to de escalate and restore a safe environment, may not understand. Being able to detect those things early is so important to prevent an escalation, prevent someone from having to go to a hospital or possibly even to jail. I've certainly worked with folks who were taken to jail because they didn't understand the person's needs. And we'd like to avoid that, certainly if we can. And so who's going to notice the early signs of a developing crisis? And it's going to be us. Those folks who are on the support team, those friends, family. Sometimes it's clergy members, people who are members of your congregation, other community members. It's us. It's the circle of support around a person. We're usually the first ones to detect when something is wrong. Could be a behavior analyst, could be a therapist, anyone who knows that person who can say, I've noticed there are some changes this person is going through that we need to address before they get worse. So, the key to the early detection of a potential crisis is that power of love, empathy, and care. It's involving people in their own planning as much as possible and surrounding them in support in good times and the difficult times. There is a relationship built on trust and a mutual understanding of respect. When we know that a person has some wonderful characteristics, a person who's a brilliant artist or musician, someone who goes to work regularly and serves people with pride, and we see a change, a disruption. As a team member who knows a person well, we can say, this is not someone who normally misses work. This is not someone who normally yells at someone or is rude to them. We need to be able to step in and support because we know this isn't typical, right? This is a time for us to reach out with empathy. If you've ever had a tough patch in your life, and maybe you spoke to somebody unkindly when you normally wouldn't do that. And I mean, we don't mean to do it, but I think we all do from time to time. Being able to detect those signs early, pull you aside and say, hey, you all right? Is there anything we can do to help you? Can make all the difference. So the person or self advocate may not be able to express a change in mood or behavior. They may not be able to tell you, hey, I don't feel right. Something seems wrong. They may not be able to communicate it to you vocally, verbally, or through sign, or even alternative and augmentative communication devices. May not be able to tell you, but they may show you with alterations in their behavior, what's typical, right? So then we got to look into whether there might be a trusted peer or a family member or a person centered planning team member who can help identify signs something has changed. Maybe a behavioral escalation is forthcoming if something doesn't improve. So I once worked with a woman in her 30s who was the most pleasant, sweet, kind-hearted. One of my favorite things she would say was, I pick you. She would come to you and say, I pick you. And that was like the thing she would say before you'd get a hug. I pick you was like the way of her saying, you're my favorite at the moment. I mean, I don't even know how many were her favorite that day, but I like to think it was pretty special. When she was quiet and withdrawn, and sitting in her room in the dark, sleeping too much, we got nervous. What's going on? She's not picking anybody. She's not hugging people. She's not out in the commons area of her day program. Started to worry something was wrong. And it turns out, after some investigation, she hadn't had her medication in 3 days. There was a medication error. So that alteration in very typical friendly behavior to this reserved, quiet demeanor and just the way she was behaving seemed wrong. And so after her staff and I looked through her record, we found she hadn't received critical medication for a few days. That required resolution on another level, but it meant we needed to be able to detect that change. So that's something that's really important. So again, who's going to notice these signs? Obviously the focused person and self-advocate. Sometimes we have folks who can tell you, I just feel sad. They're telling you, I feel sad. I feel like crying, or I am crying, or I'm not eating. I don't feel like eating. My appetite's changed. People who can tell you, they're the ones that are experiencing it firsthand. If they can't tell you, maybe they'll tell you with certain types of behavior that are different from usual. The other group is going to be a person-centered planning team. Whoever that support team is that knows the person well, people who care about that person and are dedicated to working with them and making sure that we're guiding their access to preferences and the ability to live the life that they choose to live. These are the folks that are going to wrap around a person with that love and empathy to be able to work through even the tough times and be ready to respond. So now it's up to you. We're going to ask you to give one reason why early identification of a developing crisis is important. And this is not one that you're going to be harshly graded. It's, what do you see when you're out there working with folks that you support or that you know? What are some reasons identifying a developing crisis early is so important? What can we do?
So the intervention may not have to be invasive or as serious.
Agreed.
Well, you can be proactive and don't let the crisis escalate.
Perfect. Well said.
Avoiding the individual blowing up and being Baker acted. Yes, very
Right.
Florida centric. To act quickly. Yes, timeliness is a good thing.
Right, right. I used to take statewide data on people who visited the emergency room or mental health facilities and report that at the state level. And one of the things we noticed is that there were some people who had a recurrent pattern of going to the emergency rooms, going to the mental health centers for care. And our goal was to try to detect those signs as early as possible to avoid them having to be hospitalized. You lose so much of like your rights when you're put into a facility and treated, around the clock. You've got people coming in checking on you. So we try to avoid that because it can be so traumatizing for so many people. Can we avoid the Baker Act, the 5150 holds, where someone's getting a psychiatric assessment up to 72 hours? Can we avoid having someone needing to go to a facility for stabilization? In the case of the young woman I told you about earlier, who started to show those signs and symptoms that were atypical, she was withdrawn, she was crying, she wasn't approaching you to give you a hug. Those kinds of things seem maybe a little minor, wouldn't be characteristics we'd worry about in some people who aren't as gregarious and outgoing. But for her, it meant, let's do something. Well, we were able to avoid a psychiatric hospitalization because the team was able to look into it and figure out there's another problem, and it's medical, underlying medical issue. So that would be the goal. Thanks for your participation, everybody. It means a lot. Was there anything else that popped up? Okay, great. Okay, time for a quick quiz. Multiple choice. It is important to identify signs of an impending crisis so people who support the individual can. Is it A, contact the proper authorities in a timely manner? B, immediately correct the behavior of the individual? C, tell the individual to calm down? Or D, prevent escalation and risk of harm? Please pop your answers in the chat. We'll talk about them.
Going with all D's, D, 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 D.
All right, right on. Prevent escalation and risk of harm. That's the goal, right? We see things getting worse. We know we need to intervene to try to help and support and bring those things back down. Perfect. So we're going to take a little step into planning proactive trauma-informed care. And so one of the things we talk about frequently at NADD and as we meet to talk about crisis prevention strategies is that we can always assume trauma has occurred in a person's life. And then we work to identify sources of past trauma. So what we do to do that, we can talk to the individual if it's feasible or possible, if we can ask them, like, what are some things that have happened in the past that maybe were stressful. We can ask them what helps them feel safe and help them by creating a safe space for them They know we're going to listen, that we're going to respond if they tell us there's a concern. If we're able to talk to folks, then that would be an important thing to do, if they're able to talk to us about those things that are important to them. We also want to make sure that if there is a team of people around the individual, this could be family members, clergy members, friends, co-workers, therapists, make sure that a team that we've identified has that same understanding of how a person is functioning when they're at baseline, when things are stable, when things are good. How can we tell when someone is happy, when they're relaxed, when they're engaged? That's using a little bit of Greg Hanley's wording there, but how can we tell when somebody is just stable? They're doing well. And then we want to make sure we conduct record reviews and read about past incident reports. It's important to note on that first bullet point that there are times we may not talk to a person about things that have been stressful for them in the past. If it is more upsetting, if it might re-traumatize, we may not discuss those things with them. We may ask if it's their preference to put it behind us, and we'll talk about it with others. It may be that the person should not be present at certain times when we're talking about stressful events. Over the years, I've talked to lots and lots of folks who have said, I don't want to talk about my dad and my relationship with my dad, or I'll cry. It could be upsetting. And that's okay. That's their choice, just like anyone else. We want to make sure we use words to minimize re-traumatizing a person. So in other words, we might just be very cautious about talking about anything in the past. We might say things like, when Jimmy went to the hospital in the past, we made sure he got the help that he needed. Instead of, I've actually heard some folks say, when you hit someone, we had to call the police to come and get you. And it could sound just a lot more threatening, and even like you're blaming the person for a past event. So instead, we might not talk about it at all in their presence, or just remember to be respectful and sensitive to their individuality when we talk about these kinds of things. So in other words, you know, remember the last time we got you help, or know that we're always going to be here to help you if you need us. So we're going to offer choice for the person to remain or leave the discussion. So if we're going to talk about a past event and we're in a person-centered planning meeting and we have a lot of folks present, we might say, hey, we're going to talk about what happened last week. You can stay if you want to contribute, if you have anything you want to add, but you could also leave at any time if you don't feel comfortable. Just depends on the person and what their choices are, what they're able to understand. I usually believe and treat any person as if they understand everything I'm saying. No matter what the chart says, I always expect people to treat me the same way I would want to be treated. That's the golden rule, right? And I say that because I've certainly read a chart, gone to see someone for the first time. Memory comes to mind of going into a classroom and hearing that this child, it was a teenager, didn't understand most verbal commands, didn't respond to others, just kind of off doing his own thing. And I was sitting in the back of the room trying to very quietly take notes on a piece of paper about what I was observing. And he turned around, looked straight at me, and went, "What are you doing?" And he pointed me out. And I thought, well, I thought I could be invisible, but not today. I believe that he would understand a lot more than we might have even suspected. But, treating everybody that same way has always served me well. I'm usually going to talk to the person who's present in the room instead of referring to them as, our person, right? This guy over here, this person. I'm going to talk to them directly if I need to, because I think that's just respectful. So, some ways we can plan proactive trauma-informed care. We note that traumatic events are often unique to the individual. Things like seeing an ambulance, or hearing an ambulance, even seeing a police officer, or even anyone in a uniform, hearing someone shout or speak above a typical conversational level, or even going near locations of a past traumatizing event. All of these are examples that a person may have experienced in the past that resulted in trauma. If we're able to identify those things, we may be able to either avoid them or plan ahead for what we're going to do. I got an example coming up of this, but we may be able to help plan, because Ambulances are going to pass by. Police officers and other people in uniforms are present. So we may just be able to provide more calming strategies for them. We'll talk about it. So, just as identifying behavioral events that signal impending crisis is important, we also need to describe possible traumatizing events and work to avoid them. So, ways we do this: getting input from the individual supported. What are some things that are important to you that may have been traumatic? How can we avoid them? Gathering input from the treatment team, because you might find mom or dad or a therapist or someone else who's detected some of the events that were stressful in the past that produced trauma. We want to make sure when we identify those things, we put them in writing and then we add them to a comprehensive plan of care. Okay. So it's important that we don't just become these keepers of the information ourselves. We want to share them with others who care about our person, who care about the person supported. And putting that in writing somewhere that we keep and that we know this is when we need to make a call. This is when we need to contact the physician. This is when we need to check in on a person. So critical. And so this slide is referring to some of the diagnostic information and vulnerabilities that we may see in folks who have intellectual or developmental disabilities, mental health conditions, communication challenges, and past social or emotional difficulties. So those collected, any of those, sometimes we see people with multiple of those types of conditions or challenges within a single person. We could see that happen in a single person. Those issues can lead to traumatic experiences and can lead to erratic, dangerous, or other types of concerning behavior that look like crisis, right? So there can be increased vulnerability to trauma if there's a history of traumatizing events. Some people have difficulty thinking ahead or planning how they're going to react to things. There are some that we see who exhibit like hypervigilance or defensiveness. Maybe there's a quick reaction to something that occurs when we can teach them to like de-escalate and calm themselves. They may misperceive help as a threat. I know that in some cases I've seen precursor behaviors in a person who gets right in a person's face, like, hey, what's going on with you? And it could actually be perceived as more of a threat than a supportive act. There may be decreases in adherence to planning that we've put into place, reduced social supports if people are sort of disappearing from teams. Maybe they move on or they just no longer know the person as well. And we can have development of other conditions, so other diagnoses, mood or anxiety disorders, PTSD, post-traumatic stress disorder. And so in the context of a developing crisis, there are diminished coping strategies. So we may see problems with emotional or behavioral regulation, negative affect. I mean, certainly if you think about driving in traffic and somebody cuts you off, you may have problems yourself with emotional or behavioral regulation or negative affect, aggression. We may see destructive behavior, self-injury, other types of high-risk behavior. Altered brain functioning is a way of just kind of describing that we're not thinking clearly. So when we're getting to that point where we're escalated, we may not be able to hold on, take a breath, take 5, right? We do experience increases in stress hormones. It's just an automatic, rapid process. And so we also may experience fight, flight, or freeze responses in a person. And some of us do a combination of these things where we just freeze. We fail to act at all, or we fight, or we leave the scene. So this is a story of Bart and his trauma-informed care. So Bart was a 56-year-old man who was diagnosed with severe intellectual disabilities, autism, and a mental health diagnosis of schizoaffective disorder. And schizoaffective disorder has some similarities to bipolar disorder, where you can have like a manic phase or a more increased phase of behavior and more of like a depressed phase, okay? So in a prior incident, he was found wandering downtown after running away from home. He was screaming at passersby, and he threatened to hit strangers if they approached to offer help. So when 911 was called, the police assumed he was under the influence of drugs. As they restrained him, he became aggressive, and his legs were skinned by their boots, and his arms were bruised in an attempt to hold him. So to date, when he sees a person in uniform, he often covers his ears and yells, "No, no, no, woo, woo." Okay, so this is a sign of a very distressing state. These are behaviors that you see that indicate Bart is at a highly escalated level just from his past experience of trauma, hearing a siren. So his team understood Bart was scared of the loud police sirens, and they agreed if he did elope from the home, if he left the home, went to an unsafe place, they agreed to follow him for his safety and asked others to avoid calling 911 unless it was a last resort, so risk of harm to self or others. In case there was ever a need to call 911 in the future, the team agreed to ensure the 911 operator would be told sirens would scare him and to let first responders know a person from his team would be there to help de escalate the situation and for them to speak with Bart in a calm and quiet voice. This is an example of a plan to try to counteract that prior trauma. And I can tell you that if first responders show up and they perceive a threat or a really harmful situation, they're going to do what they can to de escalate. But if we make that call, we have to call 911 for safety. We can't explain. This is a person who has an intellectual disability, a diagnosis of autism, lower verbal abilities. But if you'll let us shadow him and provide support, we would like to be able to work together and work with them. And I do think many first responders are willing to do this. It's been my experience that they want to know. I've had many conversations with LEOs and other first responders who say, we'd like to know how to support people better. We just really don't have the training. We don't know enough about what to do if we encounter someone who's in a highly escalated situation. Okay, so knowledge check time. What is one way support team members can use trauma-informed care to support a person who is vulnerable to crisis? And so this is open-ended. And please enter some thoughts, ideas that you might have in the chat. What are some ways support team members can use trauma-informed care to support a person who is vulnerable to crisis? And think about cases that if you've known someone who's vulnerable to crisis, what you do to try to provide support.
Having a plan ready.
Certainly. Very good.
They're working on this. We're about minutes away from the halfway mark, so they are critically thinking.
Okay,
Uh,
good.
Informing others who interact with individual of any triggers that may be there. The approach for facing the crisis.
Very good. Right, that comment about having a plan that comes from talking to people who know the person well, from offering support and empathy to that person in a behavioral crisis to try to avoid further trauma. Thank you for that. Thank you for those comments.
Talking calmly, getting more information.
Talking calmly is really important, and it can be hard because I know when you're faced with that situation, you might also be a little bit escalated. You're nervous, you're hyper focused and sensitive to what's happening, and so slow it down. That's what I tell myself. Slow it down, take a few deep breaths. I tell students of mine when they're faced with a really stressful situation, someone stressing them out, whatever it is, to try to just take at least one deep breath in and exhale, and then answer on the exhale if you need to. Just and then change the subject or redirect to something new. Some pre-crisis prevention strategies. So, some of the things we do, we're going to talk about these, break this out a little bit further for you. Emotion identification and emotional regulation. So, some of the things we'll talk about: zones of regulation, breathing and muscle relaxation, and mindfulness training. We're going to talk about some wellness interventions. So, exercise and diet certainly is important, social and recreational activities, medications, pain management, communication strategies. So, like promoting speech and communication, visual systems, assistive technology, which is better than ever. Identifying and building on strengths. We're going to talk about signature strengths, goal setting or person centered planning. We're going to focus on that. We're going to talk about some social skills training and peer supports. So get ready. Here we go. Involving individuals in their own crisis prevention and crisis response planning. So that's a starting point. So there are a few slides here. I know this is a little small, but again, these are some resources that you'll be able to access in the content that's shared with you. So in 2023, a group of self-advocates got together to try to develop a way for people with IDD and mental health conditions to discuss and document important aspects of themselves related to crisis. So on the left, you see tips to manage triggers. And so the first question is, what are triggers? So triggers are things that make you remember something that has happened to you. They can be people, places, smells, sounds, tastes, or things. For example, if someone who hurt you smelled like smoke or perfume, those smells might make you remember what happened. Triggers can make you feel scared or anxious. Our minds and bodies might explode with feelings. When you remember bad things, you might feel sad, mad, or scared for a while. Okay, so this worksheet prompts a person and or their team to talk about what those triggers are. What are my triggers? All right, anybody, if you feel like putting something in the chat, what are some triggers that kind of get on your nerves? They may stress you out, things that may make you behave in ways that you wouldn't normally behave. Triggers. You can go ahead and pop some things in the chat. And so you think about those triggers. Maybe you don't want to confess to it yourself. Maybe it's someone you support. Okay. You could say something else about a person that you support. What are some things I can do to be okay when I get upset? So maybe taking a shower, taking some deep breaths, doing some yoga, listening to some music, going for a walk. What are some things you do to help yourself calm down? And then helpful support. So, what can others do to help me be okay? For example, if a person's able to tell you, honestly, there are times I just need a hug, or I just need some quiet time by myself, or time to read a book, or listen to some music. If they can't tell you, then maybe there are some other examples of things that people around the person have observed. Like just some quiet time in his room seems to stop the body rocking or the rapid speech, for instance. So that's on the left side, tips to manage triggers. I don't know if anybody typed anything in there, but that's okay. The right side of this page is on what to do when I don't feel okay. And I urge you to like look at this reference and resource from the link center and click through some of these little links here because they're going to tell you some things to look at and think about, like what's a crisis? Why does it happen? What is a crisis plan? So I think there's some useful tips there to help you be able to identify for the person that you support or for them to identify for themselves what happens during an escalating crisis and what they can do, what we can do to help de-escalate. This is another resource. This is the website is listed at the top, nrc-pad.org. This is from the National Resource Center on Psychiatric Advance Directives. Okay, so you can click through on this website by state and pull up psychiatric advance directives. They are used to help people create a plan for what to do if a crisis is occurring or perhaps soon you like detect signs that it may be about to occur. And so here's an example on the next page, but it's important to note that you can select a state and you can click and look through legal documents that could be notarized and made legal. So here's one example of what it can look like, this crisis plan worksheet. And so this starts with signs of a crisis. And again, this is why I had the examples of like looking through what it actually looks like when a person is experiencing crisis. So not just saying someone's anxious or sad, but what does the person actually do, right? Do they withdraw to their room? Do they cry? Do they make comments about wanting to harm themselves or others? Do they make threats? What are the signs of a crisis? Okay. And so it says signs of crisis. Think about the last time you knew you were in crisis. What were some of the signs or symptoms something was wrong, or the things that things were getting worse? So, not sleeping for a few days, drinking more than usual if it's a person who drinks alcohol, for instance. And then be specific. Triggers for crisis. What kinds of triggers or situations may cause a person to experience a mental health crisis? Think about the last time the person was in crisis and what events led up to it. Okay. Could be something like getting fired from their job or having a relationship breakup, right? Could be any number of things. Hospitalization prevention. So, what could help us prevent a mental health crisis? And consider what you or others can do to help keep the person from an unwanted hospitalization. So, examples providing more social support from people who are watching out for that person. It could be calling together a team to come over and do more checking in on a person. Or in some cases, when I've worked in systems that provide in home services, providing extra staffing so someone can go in and check every 15 minutes or 30 minutes to make sure the person is okay. So even though this is small, it's not intended for you to take it all in at this exact moment, but it's making you aware of where you can find this crisis planning worksheet. You can click on that link when you get the materials and be able to look at it and focus on building a team around a person so that you can develop a plan, crisis prevention plan. And since we live in such a great world of technology and access, I thought I would tell you about this Red Panic Button app. I have it on my phone and I tested it out. It's uh it's a simple app you can load. You can use it for free. You can also have a paid version that provides a few more options. But here's what happens. I did have a video for this that my daughter was acting out to show how you could use it. But I'm going to walk you through because the video wasn't super clear. If you click this redpanicbutton.com, you can see the link to find out more information about the app. It looks like this with a big red button in the middle of the screen. And if you do want to look at the video of my daughter Bella, Mark and my daughter Bella, using the app, we'll make that video available to you elsewhere. It just didn't work in the webinar. So what happens is you can have that button right on your face screen of your phone or the person that you support. They push the button in the app and it immediately will alert first responders and identified individuals of a location via GPS. So you don't have to dial 911. You literally just press and hold. And so you'll have a few seconds to either keep holding it or let it go, and it'll ask you if you want to cancel. It will send a text message that you can either script out in advance that says, I need help, or please call my mom. Here's her number, whatever. You can set up that text message. It will also take photos from front or rear cameras to show where you are. You can also set it to record as a distress message. I need help, and that'll send to your team that are identified. It will take brief videos as well if you set it to do that. So planning in advance, like that prior crisis plan that we just shared a couple slides ago, you can also do that with this app and figure out how you want to notify a team when someone supported needs help. It's available on phones or wearables, so Android, Apple Watches as well. It'll make calls to emergency services. It'll send SMS messages. It'll go through email. It'll go through Twitter, which is now X. You just push it and it'll immediately send out an alert to the people that are identified. So that's a way to help keep track of folks who may be out and about in the community, who experience some kinds of signs of maybe they're experiencing a traumatic event that was a difficulty in the past, and they can alert people that they need someone to come and work with them or sit with them or call 911. Okay, little quick quiz time. Malika, who is usually very outgoing and friendly, suddenly starts staying in her room, refusing to talk to anyone, refusing to eat or drink, and crying for 2 days. In the past, Malika, who has a diagnosis of major depressive disorder, demonstrated these behaviors before she had a serious episode of depression. The next thing her caregivers should consider doing is it A, contact her support team to determine the next steps in her care, B, prompt her to shake it off, C, get her a puppy or kitten, D, explain that her thoughts and feelings are not real. So pop some answers in the chat. What do you think?
You're hearing all A's.
All right. That's great. That's what we want. That's what we want to see, right? It may be tempting to tell someone, "Oh, you got this. You're going to be okay." But it might be best. I often think about that strength in numbers when we talk about developing a team, because there may be times that other people know things or want to share things that have worked for them or been successful to help de-escalate. And we need to get the team, the Avengers, assemble. We want to be able to help people. So some wellness interventions that are so important. We can help a person to maintain optimum health, reduce stress, reduce arousal, like that hyper alert state, and support recovery during a crisis. So some wellness interventions include exercise, deep breathing, muscle relaxations like yoga, stretching, healthy diet, providing social and emotional support, and engaging in preferred activities like music, art, dance, or other creative outlets. So there's a whole sphere, like when we think about our lives and what's important to us, what our values are, it's important to figure out how we can help support a person by promoting healthy behaviors that encourage better wellness. So one is deep breathing. Okay, so I know what you might be thinking. I breathe all the time. What's the big deal? Why would this really help me? My own kid says this to me. Why would that help? If you're learning to do deep breathing, it's incompatible with panicking. The problem is if you don't plan it in advance, that you're going to practice how to do it when you're in the middle of a panic situation or a stressful situation, it's going to be harder to do. So practice deep breathing. Okay, I think probably most of us are familiar with this and we've done it at some point. And even if you're not consciously aware, when something big happens to you, like someone, I don't know, cuts you off in traffic or calls you an ugly name, or gosh, I was walking into Target the other day and a guy shut the door right in my face. And it's like, okay, I can get my own door. That's all right. We take a deep breath. So when our stress level rises or you experience a difficult emotion, you might notice physical sensations in yourself, rapid heartbeat, feeling a little ill, feeling unwell, feeling dizzy. Notice that you're taking short, quick breaths, or you're feeling hot, red-faced, right? These are things that we can describe about ourselves. We can look for them in another person as well that we're supporting. And we can talk to them outside of the stress context first about, let's just take a few breaths together. Can we just focus on the breathing? Because it interrupts that cycle stress has on our body. When we're doing deep breathing, our heart rate and blood pressure start to return to normal. So if we're able to practice with meditation and mindfulness, I mean, play the music. If there's a candle that you like to light that smells really good, that's what you light, right? If you have a dog, you have a cat, you have a ferret, a parrot, whatever, get your pet close to you, your pet buddy close to you. It's amazing how good a hug can feel too, right? Like I think that we probably take hugs for granted. Sometimes just having someone reach out and give you a hug is just what you need. Take a deep breath, get a hug. Hug your cat. So the deep breathing also leads me into talking about box breathing. I've done this many times myself, and I've done it with other people that I support and work with, right? So one way to practice it is you can start by exhaling all the air in your lungs, exhaling for a count of 4. So you can do it with me. You ready? You don't have to be on camera, so you don't have to look silly like maybe I will. Okay, slowly exhale for a count of 4. Hold for a count of 4. Inhale for a count of 4. Hold your breath again for a count of 4. And then just repeat as many times as you want or until you feel stress reduction. It's amazing how much it can help if you do it. Even if you feel like you're panicked, freaking out, can't cope, don't know what to do. Teaching other people to do this can be a really valuable strategy too. Some other literature-based examples of how we can de-escalate and produce calming. One is progressive relaxation training, and you can look at this paper by Manzoni for a 2008 meta-analysis where they looked at a lot of literature from other researchers. This is gradual training to relax muscles of the body. And so essentially it's relaxing postures or just being able to calm, like starting with your head all the way down your body to your feet. So 10 years of data have shown, and it's even more now, that it's effective for reducing anxiety. Okay, turn your light off in your office, slowly try to relax all the parts of your body. Another is behavioral relaxation training is very similar, and you can look at some of the references there. Theodosia Paklowaskij and colleagues, Roger Poppin, Schilling and Poppin. This is something I've used with people with more severe and even multiple disabilities to try to teach relaxed postures outside of stressful contexts so they can sit in a comfortable chair. And we talk about like relax your face, like close your eyes, sit in a comfortable chair, close your eyes. Slowly feel your forehead relax, your cheeks relax, your chin, and we're going to relax your chest. And you can work all the way through the body to try to help people learn calming postures. And so there's good evidence that this reduces stress, helps people tolerate stressful situations better. I've done this with folks I had to take into doctor appointments or dentist appointments that they were resisting. Let's sit in the waiting room. We're just going to relax, slowly inhale and exhale to calm ourselves, head to toe. You know what? I don't really care if people look at me like I'm a little weird. I'm kind of used to it. I'm just going to chill out, put on some quiet music, and close my eyes for a minute. Emotional identification and management. There is a curriculum called the Zones of Regulation curriculum. I bet some of you may have heard of this before. And it uses words and pictures to help a person identify their emotions and learn strategies to manage their emotions. And so one of the ways that you may have seen this before is with like a color identification. So in other words, there's blue. The blue zone is associated with being sad, sick, tired, or bored. So it's like that low energy, like level that we need to look for if someone is less active than usual. Time to check in. Green is where we love to be. Green is happy, calm, content, ready to learn, and focused. Yellow is when a person may exhibit maybe kind of more hyperkinetic, a little more motion. Maybe they're showing a little bit of loss of control, right? So like jumping up and down, getting louder, etc. And then of course, red is when we're seeing someone who may be yelling, hitting, really exhibiting behavior that's out of control. Okay, so emotions are within us, but our behavioral output is what may be detectable to others. So we can help people identify, it looks like you're starting to get a little more active. Like, what can we do? Can we play some soft music? Can we practice some deep breathing at that level when someone's yellow to try to help restore to green, right? Back down. Okay, quick quiz time. Caregivers and loved ones may find that blank is an effective strategy for de-escalating a behavioral or mental health crisis. What do you think? A, ignoring the person. B, asking the person to stop doing what they're doing. C, box breathing. Or D, threatening to remove preferred activities as a consequence for further problem behavior. Please pop some answers in the chat. So A, ignoring, B, asking them to stop, C, box breathing, or D, threatening to remove preferred activities. What do you think?
These are rolling in.
D's?
C's. C,
Oh,
C, C.
scared me. I was like, no,
C's. The
oh no.
C's are rolling in.
Much better. See, and I often do the ASL in here and I'll be like, oh, don't do that if they don't know. Okay. Right. Box breathing. Okay. Great. Deep breathing, box breathing, yoga, all of these kinds of things can be calming. Thank you for your responses. It's really helpful. Uh, what's really tough is when you see a lot of the D instead. People who are saying, you better stop that or I'm going to take away your movies or you're not going to have your magazines or blah, blah, blah. When someone is escalating and you make a threat, do you kind of know how that's going to go? Usually it's not going to get better, right? It's actually likely to escalate because now you're threatening them. We don't want to do that. We want to keep it calmer at a lower level. Okay, so communication is so important. And so, along with teaching emotional recognition, we need to teach people how to learn words or symbols to communicate their emotions. And so this is something we can't do in isolation. We may need speech therapists or others to help us know the best methods of teaching communication. We want to work to understand the person's communication strategies at present and be able to provide breaks, choices, or reduce demands at times of stress. We can use visual systems, so we can use the zones of regulation to ask people like, where are you right now? Are you blue? Are you yellow? Can you touch a picture to show? Sometimes using PECS, if anyone here is familiar with using the picture exchange communication system. I've certainly worked with lots and lots of kids who can point to a picture or exchange to say mad or sad. A lot of folks are using their phones or other devices, tablets, to use Proloquo to go, which is an app that will help them with selecting and communicating what their feelings are, or how they're managing. And so we can help support effective communication when a person is nonverbal or overwhelmed by stress. They may be able to touch a picture symbol or hand it to you or show it to you on their phone or otherwise, sign. Sign is a real language if they're able to tell you and show you, though we may know that we need to provide more breaks, choices, reduce demands. I work with a lot of students who work with early intervention. And so they're working with young children with diagnoses of autism spectrum disorder. And so one of our important things we do is like talk to the team, talk to mom when she drops off or dad when they drop off in the morning. How was his night? Did he eat? Did he sleep? Are there any things we need to know? And be ready to alter a little bit of our planning. So maybe on a day that the person didn't sleep well or they didn't eat, we're going to provide a little more soothing environment, less demands, more breaks. Check in with people first before we just do it, but it's important. Goal setting. So goal setting is essential to motivation and helps an individual feel in control of their relationships and activities. So person-centered planning, which we mentioned earlier, is an evidence-based practice for helping people feel empowered through self-determination. So one of the expressions we used to use in teams was nothing about me without me. So we don't talk about things without the person's input, without at least input from a proxy or someone who knows the person well. In pre-crisis, the person-centered planning can help aid in preventing a crisis by helping the person experience control and direction and helping others understand tasks or events that may trigger a crisis. Person-centered planning may serve as a foundation for development of a care and crisis management plan where you bring that team together to talk about how you're going to help. In my career, my history, I've worked with lots and lots of folks who were able to tell us vocally, verbally, those situations or contexts that tended to lead to escalation. So I worked with a young woman who she had this perception and she would say that she didn't like it when her staff talked down to her. I don't like it when they treat me with disrespect. Well, what does disrespect look like for you? I don't like it when they say, go clean your room, go clean your kitchen. It's my kitchen. It's my bedroom. I can keep it the way I want. Don't talk down to me. Don't tell me what to do. Okay, so what are some ways that we might be able to talk to you a little bit better about it? Okay, can you just say, hey, I could really use some help. Would you rather I come in and help you put your sheet on, or would you rather do it yourself? right? Uh, Offering some choices was a big deal to her, being able to have some choice in the way that she does things. Um, Otherwise, there were a lot of really aggressive episodes for this person. But we also had to do some goal setting. Like, listen, we're here to support you, but there are some things that you have to do too. You have to be sure that you're not yelling at people, threatening people, hitting people. Can we agree that if we offer support to you and we offer to give you choices, that you'll keep yourself calm or you'll ask for what you need and we'll help you? And you know what? Nobody's perfect. With this plan, we had a behavior contract. With this plan, sometimes things still went wrong. And I used to think about it like, ah, things went wrong. Like, what do we do? And I started to look at it a little bit differently. When things do go wrong, it gives us a little more information we didn't have before, right? So it's a learning experience. It's a way for us to be able to say, we're going to plan better the next time, right? I think that's what it's about. Being able to build on a person's strengths and abilities. So I think it's important for us to identify and use a person's strengths to help them regain control as a crisis is developing. So it's kind of like getting in touch with their values and things that are important to them. And if they're not a person who's able to vocalize them to you, the people around that person who support them will be able to help us identify those things. So if we know that a person is that it's really important to them to be a friend to others, that they're trustworthy and honest. You can remind them, like, you're such a good person. The way you care about people is one of the most important things about you. It's something everybody loves to see you. People like having you in their lives. You're a great friend. Those kinds of things where we're building on somebody's capacity and strengths are so important. Something else, when I said I don't talk about people in front of them in any sort of way that I wouldn't want someone to talk about me. Another thing I think about is how important it is to tell people that you believe in them and what they can do well. If you're thinking about like putting something in writing in a plan or things that we say, I think it's so important to be very respectful. Whomever we're talking about, that we're saying things like, I believe in you. You are good. You are a good friend to others. You're a great listener. You're a great friend. These are strengths, right? Instead of talking about or focusing on the things a person can't do. I always hate that part of a plan where people break down weaknesses. And I'm like, it's just future opportunities. I know that maybe sounds like it's positive psychology, right? It's a branch of positive psychology, but it can apply in behavior analysis as well. Increasing friendships and making positive statements about other people, kindness. We can figure out ways to increase those and make them more evident to the people around us. Social skills development is so important. So peer supports are still really important in all of our lives. I think the folks that we support as well who may have intellectual developmental disabilities, mental health challenges, maybe we can help connect them with others who have similar types of experiences to be able to share and interact with each other. And so what this is, it's not really based on these psychiatric models or even diagnostic criteria. It's empathy through shared experience. So there are peer connections that people can make. The focus is on health and ability instead of illness or disability. And so it involves including information, training, skills, and a positive social climate. There are several curricula that can be used for this. One I'm a big fan of is the Peers curriculum by Laugeson and colleagues. Different versions are listed here. And so these are like manuals that have different scenarios and vignettes to work through, and you could apply it to kids through teens and young adults. And you just teach them with role plays and examples where they can interact with each other. I'll give you an example. One of my favorites was how to tell jokes. And so I did this with a group with kids that were about 15, 16 years old. actually they were like 13 to 16 years old. How do you tell a joke? And then how do you tell if your joke was received by others? Did they look at you and laugh and like nod, or did they like roll their eyes and turn away, right? How to receive a joke. Also, if someone tells you a joke, do you respond with sarcasm, like, ha ha ha, that was very funny? Maybe it wasn't, right? Maybe you can say, I don't know if you should tell that joke. So this curriculum will go through specific scenarios that you could role play and model, to give examples and give people opportunities to practice with each other. The teen group would also like plan or like play dates, like get together, like, let's get together, hang out at the mall. Like, how do you make a phone call, right? So we practice that kind of stuff. Bellini and colleagues have worked on this building social relationships. So it's also focused on children and adolescents diagnosed with autism and other social challenges. There are assessments and also some session plans that they can practice. Some great curricula for this. So a knowledge check. Here we go. What is one prevention strategy you might use to de-escalate a possible crisis? So you see someone's escalating, they're starting to show signs. What's something you would do to help de-escalate or have done?
Right, and visuals to support communication.
Mm-hmm. Love it. Visuals to support communication.
I was thinking one I found out about today was providing stuffies, stuffed animals.
That's a good one, right? Who doesn't
For
love a
some
good
people, it
stuffy?
works.
I know. I like hugging up Stuffy.
Yeah.
I have my Choco Cat plushie that I like to cuddle at night. It's just it depends on what the person needs, right? A body pillow, a plushie. Sure.
Yep. Yep. Elizabeth is agreeing with that, giving something soft to relax.
Mm-hmm. How about staying calm? Someone may be yelling at you and you get calmer. True story. This is years ago. It was on my birthday, and I had a road rage episode. It wasn't me. I caused it, but I didn't mean to. I accidentally cut somebody off because I thought they were turning, and then they turned their blinker off and decided to go straight. And so I kind of scared them. And I did the uh-oh. So this woman followed me, horn blaring, honking, honking, flicking me off through the window. It was an older woman, and she was just screaming in her car, just her tailgating me, flashing her headlights, followed me to my housing community, went in the gate and followed me through the neighborhood, low speed chase, right? Just flashing headlights and honking and flicking me off and the whole thing, just raging. So I called the police. The police were like, okay, don't get out of your car, just keep driving slowly. When we arrive, we'll meet you at the gate and we'll be ready to talk to you. So we pulled out through the gate. She pulled up behind me and the police got out and they were like, ready to see what happened. The woman runs over and just starts screaming at me. And I said, it was a mistake. And I got really quiet because she was screaming. It's like, I'm really sorry. I thought you were turning. I didn't mean to cut you off or make you have to slow down. I mean, it wasn't like a slamming on the brakes, but it was like she slowed down. It was a mistake. And so she just continued raging for a while. I just got quieter. And I was like, I, I promised it was a mistake. And the police like turned to her and they said, you are really out of control. Like you don't need to follow somebody like that. You don't need to flash lights. You don't need to honk. You don't need to do these things because it's really unsafe. And quite frankly, we've dealt with people who were killed doing the kinds of things you just did. And then she turned to me and told me I was too calm. You're a little too calm for this situation. I said, oh, I work with crisis a lot for a living. And my thought was I would just try to calm her down by driving slower and then talking quieter. I never think it's a really bad thing if you're going at it from slowing it down and getting calmer when someone is really escalated. I increase my distance, try to be supportive, not confrontational, and just get calmer, slow it down. All right, so here's our big summary. Hopefully you learned some ways to identify some pre-crisis behaviors that we want to look for and to operationalize or describe them in ways that would promote agreement between parties. Like if it's family, you come to an agreement. Like if we see the person is crying or making comments about hurting themselves, or maybe hoarding unsafe items, putting them away. I once worked with someone who would get like knives and things out of the drawers and try to put them away. We knew that was a sign we need to lock everything up in the future. Being able to identify those pre-crisis behaviors in ways that everyone would agree it's time to get active and do something. We identify signs of an impending crisis, so those kinds of behaviors that indicate that we need to react appropriately based on the situation. Maybe contacting other members of the team to get involved. We talked about planning using proactive and trauma-informed strategies. So it could be the examples of like contacting the authorities if we needed to make sure they know to be calm and quiet. Let us try to take point and interact with the person. Like Bart was the example, approaching to make sure he's safe and well cared for, being quiet. We also talked about how to ensure inclusive care planning. And so this is that idea that within a supported within a care team or person-centered planning team, having the person present and interacting if it's possible, if they're able to, and if not, that we have other people who know the person well and support them. We talked about some tools you could use to empower people with intellectual developmental disabilities and mental health in their own planning. So some of those strategies, like what to do when I'm not okay, identifying triggers, if we're able to either have them tell us or be able to detect as a team when certain events are present that indicate a possible trigger for a crisis. And we gave you some tools for crisis planning in the future, should you need it, like crisis planning worksheets. It doesn't have to be a legal, like stamped document. It can just be one that a team all shares so that we know how to interact appropriately if needed. So there are some resources to the link center, some of those documents that we shared to you. And so you can like pull up those forms and look at them if you're interested in that. There's a link to the Sunshine Health Resource Finder for people to find community resources. Some references that we talked about in the slides are here. You'll again have access to these slides. Some other references. And the last thing to say is congratulations. Almost. You've completed module 2, but we would like you to complete this final assessment to test your learning and gain your feedback on how we can improve the course. So if you're able to like pull that up as a QR code, or if Kristen or Mark are popping that link in the chat, we would love to see. I have to be honest, like in a webinar, it's really tough to not be able to see you all and interact with you directly. So, but it was wonderful to see the contributions in the chat, people who are having experiences with this. It always helps us learn and grow too. So thank you.
Yeah, I put a link in the chat for this post-session questionnaire. And again, as Celeste said, it's really for us to gauge how well we did and ways that you might be able to suggest that we improve these trainings in the future. I also wanted to add, I responded to Andre, but the copies of these slides in PDF form, including all the resources mentioned, will be provided to everybody at the end of July. And PEPSA is also posting the recordings for these sessions to their websites as well. So you'll be able to access those and re-review. I know we had a couple late folks join. Yeah, hey, what's going on? I see McHugh, and I remember you from last session. I apologize, I don't remember the first name, but thank you.
Thank you. You. That's like our fast like buzzer beater.
Yeah, from module 1.
Thank
So the recording for today's session will be available through the PEPSA website as well. Yeah, she's laughing. But absolutely appreciate you guys' time. If there are any questions that you guys want to ask, I can, if you let me know in the chat, I can unmute you and you can ask Celeste or Mark directly. We have about 23 minutes left in the training time period, so we have ample time for
I
questions.
was afraid of taking too much time, but I cut those videos, so yeah.
Yeah, if you have any questions, feel free to
Nice
type a
talking.
question in the chat. I'll unmute you and we can answer those live here.